Some patients will initially start with difficulty in swallowing with solid food. को लगेगा कि खाना अटक रहा है, easily जा नहीं रहा है. Initially it starts with solids and then it moves on to liquids. Cancers of the food pipe are quite dreaded cancers, often detected late. This was commonly a disease in the West because of their lifestyle. Hi friends, today let's learn a little bit about esophageal cancers. Esophagus is nothing but the food pipe that connects right from where the mouth and the oral cavity ends right up to the stomach. The narrow pipe that connects these two is the esophagus. So cancers of the food pipe are quite dreaded cancers, often detected late and usually associated with not a very good outcome, usually because they are detected late. How do these cancers present? The commonest way for an esophageal cancer to present is with difficulty in swallowing. Some patients will initially start with difficulty in swallowing with solid food. को लगेगा कि खाना अटक रहा है, easily जा नहीं रहा है. Initially it starts with solids and then it moves on to liquids, and some patients present with a stage where they are not able to take anything orally. And this is the commonest presentation. If we look at traditionally in India, we used to previously have a lot of what we call as squamous cancers of the esophagus in the middle part of the esophagus. And over time, we are seeing more of reflux-related disease, that is adenocarcinoma in the lower part of the esophagus, or what we call as the GE junction or the gastroesophageal junction. The gastroesophageal junction tumors or GE junction tumors are associated with more urban lifestyle because of obesity, because of irregular eating habits, which is associated with long-term reflux, where the acid from the stomach goes on hitting the lower part of the esophagus. And over time, over many, many years, this gets converted into sometimes what we call as a Barrett's esophagus. And that over time, over decades, it can form cancers in the lower part of the esophagus. This was commonly a disease in the West because of their lifestyle. Today, because of our very urban kind of lifestyle and the kind of food practices that we have and the irregular eating habits and our dietary preferences and obesity, which is growing rapidly, all this has contributed to a lot of reflux-related cancers. That these are adenocarcinomas, and they usually involve the lower part of the esophagus. So diagnosis of these patients first is by an endoscopy. A small camera is put in by the gastroenterologist, take biopsies from this to identify and diagnose the tumor. Normally we look at what is the extent of the tumor, from what level is the tumor starting, up to where is it also involving a part of the stomach, or is it just stopping at the lower part of the esophagus. I think that's very important. The other important aspect is a PET scan that actually identifies the extent of the disease, whether it's spread elsewhere, whether it's only localized, whether any lymph nodes are involved, and if yes, then what are the various stations of lymph nodes that are involved. Once the entire diagnosis is done, we have the type of tumor, then we go on to the treatment. The treatment usually involves some form of chemotherapy or chemoradiation first. So squamous cancers usually get chemoradiation first. Adenocarcinomas usually get just chemotherapy first. A few cycles of chemotherapy often works wonders in these patients. Immediately after the first cycle, patients start feeling better, they start eating better, the problem with swallowing goes down completely, and often these patients, the tumors really shrinks, and we have excellent responses to chemotherapy, or in squamous cancers to chemoradiation. Once we get a good response to chemotherapy or to chemoradiation, then we go ahead with the surgery where a part of the food pipe or the entire food pipe is removed and then replaced with pulling up the stomach and joined to the remaining part of the food pipe, or at the neck to the cervical esophagus or the part of the esophagus in the neck. Now, usually we do this with robotics. Morbidity or the complication rates have come down considerably since the time we've used robotics, because there are small cuts in the chest, which was otherwise, we used to open the chest completely 15 years back, and it used to be quite a morbid surgery with a lot of complications associated. But with robotics, that has really come down. The chest cuts are much smaller, so the patients have much lesser lung-related issues and they really recover much faster. Commonly asked question is, why not go for surgery directly? Why give chemotherapy? Is it an advanced disease? So it's been well proven in a lot of studies and a lot of literature that unless it's a very early stage disease, many of these patients, almost 80 to 90% of our patients, do require chemoradiation or chemotherapy chemotherapy first to try and shrink this disease. And it's been shown that when we do that, the long-term outcomes are much better. Patients live much longer. Recurrence rates are much lesser. And that's why it is now part of protocol. So it is very important to identify, unless it's a very early stage, stage 1 or very early stage 2, where these patients will be candidates for upfront surgery or direct surgery. Otherwise, a lot of our patients will still be eligible for some kind of neoadjuvant therapy. That means some form of chemo or chemoradiation, depending on the type of tumor, shrink the tumor, and then go ahead with surgery. Aftercare of these patients, usually the patients recover very well. And once they recover, there are certain do's and don'ts that we always tell our patients. Often these patients have a lot of reflux because the sphincters are gone. There's a sphincter that prevents reflux at the joint between the esophagus and the stomach. If that is cut, some patients will continue to have a lot of reflux. So we advise them certain anti-reflux measures. We advise them small frequent meals. Don't sleep for at least an hour and a half, couple of hours after taking your last meal. Lie down with the head end of the bed in a little bit of an incline so the reflux is lesser. And we always encourage them to have healthy dietary practices. So I think these are some of the things that we wanted to share about esophageal or gastroesophageal junction cancers. And I hope this is of benefit. Thank you.